Hi students, good morning. Man need difficulties in life because they are necessary to enjoy the success. It's said by the APJ Abdul Kalam. So, when there is difficulty in your life, don't be sad because at the end of your difficulty there is a successful in your life. Today we are going to discuss about adenomyosis. We can see what is adenomyosis. Definition: adenomyosis is a condition where there is an ingrowth of endometrium, both the glandular and stomal components directly into the myometrium. So this endometrium is inside the uterus, the inner layer of the uterus. So when the endometrium is ingrowth, both glandular and stomal components are growth inside the myometrium. It is known as adenomyosis, in which glands of the endometrium are found in the mesothelial layer of the uterus. So we can see in the mesothelial layer of the uterus there is a glands of endometrium. We can see the causes. First, it is actually unknown, but it may be due to repeated childbirth. When repeated childbirth, in the placenta is separating from the wall, so there may be some lesions are there. So that time, sometime this endometric tissue may be ingrown. And vigorous curettage. When we are doing the vigorous curettage, there may be chances of this endometrium going inside. Then excess of estrogen, which produces cyclic glandular hyperplasia of the endometrium. So these are the causes of adenomyosis. Next we can see the pathology. The growth and tissue reaction in the endometrium depends on response of the ectopic endometrial tissue to the ovarian steroids. So with the help of this ovarian steroids, usually the endometrium reaction will happen. Growth and tissue reaction of the endometrium usually happen due to the ovarian steroids. But if the basal layer is only present, the reaction is much less as it is unresponsive to hormones. But if the functional zone is present, which is responsive to hormones, so what will happen? The tissue reaction surrounding the endometrium is marked. So the basal layer of the endometrium, including the glands and stoma, is infiltrate into the myometrium. So endometrium is by the basal layer of the endometrium, including the glands, also infiltrate into the myometrium. So what will happen? Surrounding myometrium tissue undergoes hyperplasia, will be enlarged and give rise to uterine enlargement and become the this is known as adenomyosis. Okay. We can see the symptoms. Usually it is asymptomatic. Menorrhagia due to increased uterine cavity, associated endometrial hyperplasia and inadequate uterine contraction. There may be menorrhagia, and dysmenorrhea due to disturbed myometrial contraction. Then dyspareunia, frequency of maturation because of the this big uterus compressing the bladder, and pelvic discomfort because of this big size of the uterus, and backache because of compression to the back organs. Next is a signs. While doing the abdominal examination, we can see hypogastric mass arising out of pelvis and occupying in the midline. When size does not exceed 14 weeks pregnant, because of this muscle layer is enlarged due to the endometrial enlargement, what will happen? The uterus size become around a 14-week pregnancy size. So we can palpate the uterus at the level of midline of the umbilicus and the symphysis pubis. And pelvic examination, asymmetrical enlargement of the uterus can be seen because of the irregular shape of the uterus. And we can see the diagnosis. Ultrasound color Doppler, the heterogeneous echogenicity can be seen. Hypoechoic myometrium with the multiple small cysts in the myometrium can be seen. Then increased vascularity within the myometrium because of the endometrial the stoma is growth inside the myometrium. So we can see the increased vascularity in the myometrium. Then MRI shows a thickened junctional zone. This is the MRI. We can see there is a thickened zone with them, and direct needle biopsy to confirm the adenomyosis. Next is the treatment. Medical treatment include hormonal management. So estrogen and progesterone can be given. Levonorgestrel intrauterine device, that is, this is levonorgestrel intrauterine device. It is same as it is a T-shaped device like a coberting with the polydimethyl silovine membrane around the stem. So it is covered by the the stem is surrounded by polydimethyl silovine membrane, and which acts as a steroid reservoir. So it is reserved by the steroid. It is filled by the steroid, and total amount of the levonorgestrel is 52 mg. It is filled with 52 mg of levonorgestrel and is released at the rate of 20 microgram. It is not, it is microgram per day. So it is in the replace every 5 days. So it is every 5 days it is released by 20 microgram of the levonorgestrel to the body. That is also the hormone. Then non-steroidal anti-inflammatories, that is NSAIDs, and hormone therapy, the woman reluctant to undergo hysterectomy. Then Danazol, gonadotropin releasing hormone can be given, and Minera intrauterine contraceptives. We just now seen the intrauterine contraceptive device, the same as seen like a Minera. The name is the Minera, and for the Minera is intrauterine contraceptive device for menorrhagia and the pain. So when we introduce the Minera, the bleeding will be reduced, and the pain during the menstruation also will be reduced. And transcervical resection of endometrium is effective for about 2 years. Transcervical resection of endometrium can be, if we done, it will be effective for 2 years. And combined contraceptive pills, the hormone can be given. Then aromatase inhibitors and danazol loaded intrauterine system, that is just now we see that is a coberty like that. That is also danazol loaded intrauterine system can be given for the atrophy. So these are the medical management. Next is a surgical management. Definitive surgery, that is hysterectomy, that is total abdominal hysterectomy plus bilateral salpingo-oophorectomy can be done. Then conservative surgery, myometrial reduction can be done, and hysteroscopy resection can be done. Resection of the adenomyosis can be done. And newer interventional techniques are uterine artery embolization. We already shown you in the video, and endometrial ablation can be done, and MRI guided focused ultrasound surgery also can be done. So this is endometrial ablation. It is done with the it's a device and a balloon. It is also enlarged, and this is the endometrial ablation can be done. So these are the surgical management. So that's all about the adenomyosis. It was a small topic, and it is also endometriosis. It is endometrium is implanted other than the uterine cavity, but in adenomyosis, the ingrowth of endometrium to the myometrium. So I think all of you are clearly understood.